Now I move on to the third session, third topic of our first session that has been sponsored by Jagannath Gupta Institute of Medical Science and Hospital. The topic is acid-based understanding in critical care setup. Our speaker is eminent Brigadier Dr. Soumitra Chatterjee. Sir is incidentally of my college alumni. So sir is a brilliant speaker. I know him very well for years together. He really was the instrumental in taking up so many big multi-specialty hospitals. Please, Dr. Chatterjee.
Respected Chairperson, sir, and a very good morning to all the dignitaries and the eminent doctors who have assembled here, sparing their valuable time, not only that, sparing their Sunday sleep, attending 8 a.m. in the morning from a group of doctors and civilian doctors is definitely commendable. In fact, I have been doing this for a number of days, years together when I was in uniform. But after I have left the uniform, I have also become a little loose-lax. Coming down to the things that, why this topic? This is, well, I must tell you very clearly that in my clinical practice of anesthesiology, cardiothoracic anesthesia, critical care, liver transplant, in the armed forces, as well as abroad in the King's College and Mayo Clinic, Rochester, I have found, and in my teaching career also, that this is one of the topics which is a little neglected by the teachers, the students, and the clinical practitioners. I have seen that and I have realized that a reasonable understanding of this particular subject, particular topic in the critical care medicine can optimize our thoughts about the modalities of management in the various complex critical care issues, and which will benefit the patient as well as which gives the needers for our growth. Thank you. With this, let us proceed. I have divided this thing into 3 topics. This is the subject I have been teaching at Armed Forces Medical College for years together, but I have changed this over a span of time, and I have kept very little physiology part in this lecture, because I know that most of us will be attending this, will be accomplished doctors, senior physicians who will not be requiring this physiology part of that. They will be requiring the clinical interpretation and some examples to go ahead. Now, this I must tell you very clearly. Life is a struggle not against sin, not against money power, but against hydrogen ions. Well, in my teaching career, spanning more than 25 years, from AFMC Pune to Delhi University, to Bangalore University and others, even at Calcutta University, I am a teacher and examiner of Calcutta University also till date. Whenever I take the exams, whenever I go for this, whenever I ask the students, which ion do you think is the most important cation of our system? The reply promptly comes either sodium or potassium. This proves that the conceptual game from their course, medical course, have not been cleared. It is not their fault, it is our fault, the teacher's fault, not to bring up the student to that level. I have corrected, if not more, about 500 examinees in my time that the most important cation of our system is hydrogen ion, not sodium, not potassium. These are all we know, that CO2 25 millimoles per day and non-carbonic acids 70 millimoles per day. These are all written in the books. Acid-base balance, main concern, two ions, derangement, and hydrogen ion versus bicarbonate ions. The jugglery goes on between them. So this is nothing new. Now, which we should know very clearly when we are practicing clinically, that ECF acceptable compatible pH range, there is extracellular fluid, which we normally visualize by various tests. When you are testing extracellular fluid. The sodium, potassium, whatever it is coming extracellular. It is not intracellular. But we'll come later that extracellular fluid doesn't carry much importance as far as the critical care setup is concerned. Now there is chemical buffers which react very rapidly. There is respiratory regulation which reacts every seconds to minutes, and there is a renal regulation. We all know that. But have we ever realized that when we go to a critical care setup, a patient is having some renal compromise, and the nephrologist has come and seen, we are saying that, yeah, the urea is high, the creatinine is around 3.54. He said, well, we'll wait some time, and we'll see. Now it is not the time for dialysis. But have we realized that whenever a physician is coming and treating the critical care specialist, the respiratory rate has come down. The patient is not breathing properly, or the respiratory rate has gone very high. What the clinician expects the critical care? Immediately intervention. Either intubation, ventilation, BiPAP, and so many jargons going on to save the patient. Why? 99.9% of the hydrogen ions are excreted from our body through the lungs. Only 1%, 0.1% gets excreted through the kidney. So any renal problem, we can wait and watch. But the problem arising from the lungs or the heart, no. We have to act very fast. With hydrogen ion regulation, there is why respiratory regulation is within seconds to minute. If we allow the PCO2 to increase to more than 60, 70, unless the patient is a case of chronic COPD or a COPD case, it will cross the blood-brain barrier. What are acids, what are bases? We are not going to explain to this, dignitaries. They're all very, very accomplished doctors. Now, this is again from the book, pH 7.35 to 7.45, and pH 6.8 to 7.8, compatible with life. My experience of 25 to 30 years of critical care setup is telling this is not right. Very few cases below 7.1 survives. Very few cases above 7.65 survives. I've got a original paper on this at Kaplan, Journal of Cardiothoracic Anesthesia. This all we know. I'm just passing through this. Acidosis, alkalosis, 20:1. Now, this is important. 20:1 base ratio. What does it mean? One should understand that because this will have a clinical effect later on. Acid 1, base 20. So our system is basically a base-oriented system. If you turn it more towards acid, you will have more difficult issues to come forward. That means what we mean? We mean that we can wait for a little alkalosis to come, but we cannot wait for a high degree of acidemia to come. Now, this is important. As I told you, 42% of this body buffers and the acid-base regulation occurs in the extracellular fluid, and 58% occurs in the intracellular fluid. There is influx and outflux of disodium hydrogen phosphate and dihydrogen sodium phosphate. The proximal and the distal loop of Henle, remember our physiology days, regulates 0.1% of the hydrogen ion through the kidney. But how many of us remember that for potassium ions and hydrogen ions, there is a buffer system and intercellular regulation going on. Very few of us have remembered that till date, because as we have grown up, we have studied many more things, and we have blissfully forgotten some basic things which would have helped us in the critical care practice. Now, this is the interpretation part which I am coming to. When presented with an ABG report, one should be able to understand what are the things. Presence of acidosis or alkalosis. If both are present simultaneously, as is usually the case to interpret which is the primary abnormality and which is the secondary compensatory stage, is the compensation complete or it is incomplete? Is hypoxia present? If yes, is it mild, it is moderate, or it is severe? For doing this, one must look at only 4 parameters in the ABC. Report to begin with, these are pH, PCO2, base excess, and PO2. The normal values of this are given. These are the normal values. Now, why I have given mixed venous blood? Mixed venous blood represents the saturation and the level of the various parameters when they are delivering their oxygen to the cells and coming back. Now, if the mixed venous blood, PO2 is very high, above, instead of 30 to 40 millimeter of mercury, if it is 60 to 70, what does it indicate? It indicates the patient is not being able to extract oxygen at the cellular level. Then your top floor should start tickling. What should be the cause? There is a perfusion defect. What could be the cause? Is there a supply-demand discrepancy? What could be the cause? Is the patient going in for sepsis? Now, the early diagnosis of the sepsis before the symptoms comes can be diagnosed by the mixed venous blood oxygen saturation. Now, these are all we know, that metabolic acidosis, metabolic alkalosis, respiratory acidosis, respiratory alkalosis. Now, this is a very important chart. I will not explain this. I will just put this for 1 minute. If anyone wants this from me, I can send it this to by WhatsApp message. This is a very important thing. Why I am telling you that compensation versus decompensation. Now, critical care practice is not normal clinical practice. In my practice of critical care spanning for more than 25 years, what I have realized is that in a modern day scenario, I will explain it with a little humbleness.
Another 3 minutes.
It is like a T20 cricket. It is like a T20 cricket. You have to be, flexible. You have to be alert, agile, and aware. These are the charts what I am giving you as, if there is increased PCO2, decreased PCO2, what to do. I will request not to take any photographs. I will send you this PowerPoint presentation as it is, and if I am permitted. Huh? Bring the? Yeah, okay. So that's very nice. In fact, these are the things which I have discussed, if these above, below, just charts, just to have a, guideline how to go about it. This is the hypoxic range I have given. And this is very important again, ADO2, alveolar and the difference of oxygen between alveoli and the blood. Arterial alveolar oxygen difference. Now, what should be the normal? What should be the abnormal? Those things have been given. You can take the chart. But remember one thing, this plays a very, very major role in diagnosing whether the patient is going for ARDS or not. ARDS is not an immediate effect. ARDS takes 3 to 4 days time. And once it is set up, it is very difficult to wean off from ARDS. Difficult situations. Now, these are the various things I have presented, that metabolic acidosis, lactic acidosis, type A, type B, how it can happen. And this is actually a chapter which, why I have presented is that I have presented only to bring out a awareness among the clinicians that this is a very neglected subject. Because most of us, let me tell you very clearly, before I have cleared my cardiac anesthesiology fellowship at Mayo Clinic, Rochester, I was serving as an anesthesiologist in the Indian Armed Forces for almost 10 years, but I hadn't had a clear conception of acid-base interpretation. It is only when I came across a book written by Eugene Edward Shapiro, my eyes got opened, my system got changed, I became a changed doctor in my critical care practice. So, it is never late. In fact, many of us will come across these type of things in our life. And what I mean to say, that these are examples I am giving, how it can happen. This is example 2 and this is example 3. So I had to rush forward a little bit because the time is short, but however, my ideology and my aim was not to come here and give a lecture on acid-base disorders and interpretation, which takes a long time. It cannot be covered within 15-20 minutes. My aim was, when I started in the morning, to make the senior doctors, accomplished clinicians, aware of this particular subject. Thank you. Jai Hind.
Thank you, Brigadier Dr. Chatterjee, for your brilliant presentation. It will be of immense help to all our practicing physicians. And just I want to share, we have today launched our YouTube channel, and all these lectures will be available in our YouTube channel. So you can see sir's presentation in your YouTube channel as well. Thank you very much. Now I will request our chairpersons to felicitate Brigadier Chatterjee.
There is information, all the lectures are being recorded and we will upload on the YouTube. So please watch
Thank
at
you.
your home